Radomski Chapter 7 is about assessing abilities and capacities, especially range of motion, strength, and endurance. Conducting a functional upper extremity assessment, you need to screen first and see if you need an in-depth evaluation. If there are deficits, the specific areas must be documented. You can also do a functional lower extremity assessment, and you can do this in the way of ADLs, IADLs, always looking for the condition and the weight-bearing status and any contraindications in the patient's chart. You also need to measure range of motion, and typically you can assess range of motion in two different kinds of ways. You can do active range of motion or passive range of motion. Usually passive range of motion is going to be greater than active range of motion, but this is not true with all patients. Range of motion can be measured by a goniometer. You can use a full circle, a half circle, a finger, or an electric goniometer. To increase reliability in measuring range of motion, you need to make sure the alignment is correct for each joint and then that each patient is comfortable during the assessment. When recording range of motion, you need to make sure that you write down the starting position and ending position as well as the degrees, and you need to make sure that you sign the bottom of the chart. When measuring range of motion, typically the patient is seated with the trunk erect against the back of an armless straight chair, and you can do this also in standing or supine, but you need to look for active and passive measures and also look for compensatory movements. After you've completed your range of motion assessment, you need to look for which joints had limitations, because limitations can decrease occupational functioning and may lead to deformity later on. The OT can compare scores of the affected extremity and the unaffected extremity to see what the limitations are, and you need to develop treatment goals based on limitations. The goal is to reduce or correct underlying problems to prevent range of motion loss. And remember, when comparing reevaluation measures to the initial measure, improvement should exceed the measurement of error, which is 5 degrees. Next, we're going to talk about measuring pain. Pain is subjective and multidimensional. Components can include intensity, duration, and description of pain type, and then also the emotional impact of pain. You can assess this through a visual analog scale, different types of pain rating scales like the Wong-Baker, the numerical rating scale, and the verbal rating scale. It's important to know which population your patient falls under in order to use the appropriate pain scale. It's also really important to note scar tissue, especially if scars run across joints or tendons that can lead to decreased range of motion. Something that's also important to note when looking at scar tissue is size, color, characteristics of the wound and scars, and then also if there is skin puckered around the scar. Next, we'll be looking at how to assess strength. So strength is the ability of a muscle to exert force, and looking at the degree and distribution of weakness can help you make an intervention plan to remediate that weakness, and it can also look at alternative ways to perform a task. When you're looking at strength, you want to do range of motion before a manual muscle test, just to note any limitations. You can assess strength through a manual muscle test, a brake test, or a dynamometer. How to interpret a strength muscle test. After recording the muscle test scores, look for anything that's below a 4 because this is considered weak. If you have a grade 4 muscle, you might not be able to meet your occupational task requirements. And weakness could be secondary to nerve damage or immobilization, so you want to look and see if there's any patterns. The pattern of significant strength is important because after a peripheral nerve injury, muscles are reinnervated proximal to distal. The frequency of how often you would reevaluate a patient depends on the nature of expected recovery. If the repeated muscle test shows that the patient is making gains, then the program is beneficial, so its demands must be upgraded. Another domain that OTs can assess in is grasp and pinch. So to grasp, the patient should be seated in a chair without arms, with his or her shoulder adducted neutrally, and the elbow should be flexed to 90 degrees. The forearm should be in neutral, and the wrist should be between 0 and 30 degrees of extension, and up to 15 degrees of ulnar deviation, and their feet should be flat on the floor. They should squeeze the grasp assessment as hard as they can, and should go through 3 trials. When you're assessing pinch, however, you need to do the 3 different types of pinches, which are the tip-to-tip pinch, the lateral pinch, and the palmar pinch, or the 3-jaw chuck pinch. The results of grasp and pinch scores are compared with the patient's unaffected hand because we don't compare it to norms. Grasp and pinch are considered abnormal if they're associated with functional limitation and or if they're 3 standard deviations away from the mean. Grasp and pinch measurements can quickly be reevaluated over time to monitor the progress of the patient and effectiveness of the treatment plan. Measuring dexterity requires hand range of motion, hand strength, and sensation in order to manipulate objects. Occupational therapists also need to measure endurance because we can treat a variety of conditions that can impact an individual's endurance, including cardiac or pulmonary impairments, a major trauma or illness requiring bed rest, loss of significant muscle function, or the need to use prosthesis or adaptive equipment. There's 2 types of endurance. There's cardiovascular endurance and also muscular endurance, and we need to assess both of them. Measuring the cardiovascular aspect of endurance, we need to look at METs, VO2 max, RPE, and you can do the Borg talk test. And you need to make sure that their heart rate doesn't go higher than 220 minus their age. That should be their max heart rate. The role of OT in cardiac rehab are for those who could be on prolonged bed rest or any type of cardiac contraindications. And you need to look at things like self-care tasks, household management, and ability to return to work. You also need to look at the muscular aspects of endurance. Muscular fitness is a combination of muscular strength and muscular endurance. Endurance may be decreased because of local trauma or reduction of innervation. And just something to be mindful of is isometric testing can produce arrhythmias, and therefore echocardiogram and blood pressure should be monitored during isometric testing, and especially in patients with heart disease and abnormalities.